Good evening, friends. Today our guest speaker is Brigadier Dr. Sanjeevan Sharma from Lucknow. He's going to speak on TFR for CML, special challenges in India. After that, I will be giving another brief talk on unmet needs in the third-line treatment of CML. This webinar is brought to you by Mumbai Hematology Group. It is supported by Novartis and Nirvin, managed by Perfect Square. I thank Mr. Dinesh, Lekha, Rahul, and the team Novartis, Paresh and the team from Nirvin, Yash Kalpesh and the team from Perfect Square, Executive Committee of MHG, our guest speaker, Dr. Sanjeevan Sharma from Lucknow. All our discussants were themselves eminent hematologists or medical oncologists, and you participants for sparing your Saturday evening if you are from India, morning or afternoon if you are from the rest of the world. The website of Mumbai Hematology Group is www.mhgindia.com. There is no password. You can view all our future activities at this website. And we have the Essence of ASH as well as 46th Annual Conference of Mumbai Hematology Group coming up in the next month, that is 26th of January to 29th of January. And you can have a look at the scientific agenda with 9 international guest speakers. This is not a webinar. It's an in-person meeting in Mumbai. You're most welcome to attend if you feel like doing so. Tomorrow morning, we have another important webinar from Dr. Krishnaratnam Kannan from Chennai. And we are going to listen to him on managing hematological malignancies in elderly population and unmet need again. Our discussants today are very important personalities, and they have been put up alphabetically here. We have Dr. Aishwarya Raj from Ahmedabad, Dr. Akanksha Garg from Jodhpur, Lieutenant Colonel Dr. Ashok Meshram from Mumbai, Dr. Ashok Rajoria from Gwalior, Dr. Ayan Bhattacharya from Cooch Behar, Dr. Bharat Parekh from Ahmedabad, Dr. Chirag Shah from Ahmedabad, Dr. Eva Bhagat from Ahmedabad, Dr. Girish Badarkhe from Nashik, Dr. Hemant Malhotra from Jaipur, Dr. Radhika KK from Hyderabad, Dr. Krishnaratnam Kannan from Chennai, Dr. Reshma Roshan from Srinagar, Dr. Roshni Pandey from Jabalpur, Dr. Sada Shivadu Gundeti from Hyderabad, Dr. Sanket Shah from Ahmedabad, Dr. Stalin Bala Chaudhary from Hyderabad, and Dr. Thilagavathi Venkatesan from Chennai. My pleasure to introduce my friend, Brigadier Dr. Sanjeevan Sharma this evening. He did his MBBS and MD in internal medicine from AFMC Pune. Following that, he did PDF Hematology 2007 to 9 from CMC Vellore. He has been hematologist at the Army Hospital R&R New Delhi from 2009 to 2014, AFMC Pune from 14 to 20, and Command Hospital Lucknow from 20 till date. He began the BMT program of AMC in Command Hospital Pune way back in 15. On TFR in CML, timing of MRD assessment in acute leukemias. He's published over 40 research papers in various international and national peer-reviewed journals. He's associate editor of the Indian Journal of Hematology and Blood Transfusion. He's member of the Education Committee of Indian Society of Blood and Marrow Transplant. I invite him to speak on TFR for CML special challenges in India. Over to Dr. Sanjeevan.
Thank you. Professor Dr. M.B. Agrawal, sir. It's absolutely an honor to be sharing the stage with you and being invited to present talk on one of the most prestigious academic platforms that we've had been witnessing over the past 3 years or so since the COVID pandemic began. So, just one. Is the slideshow visible, sir?
Yes, sir.
Fine, sir. So, I think it was Dr. M.B. Agrawal sir who gave me this opportunity to select a topic, and since it was a part of one of my ongoing prospective trials, so a lot of data was already there with me. So I thought that on the last day of 2022, let me share some of my thoughts on this very interesting aspect of CML management, more so because CML is particularly close to most of us hematologists' heart, because it's the poster child of the success of hematology. And it has become the poster child because of some very phenomenal work being done over the past 6 decades by some stalwarts, whether it is Hungerford or Novel. 13 years later, Dr. Janet Rowley, followed 10 years later when Dr. Bartram, who as a student in his thesis told us that what that BCR ABL was, till Dr. Whitty Owen gave us the molecular characterization of the BCR ABL. And finally, of course, this everybody recognizes Dr. Brian Drucker, the creator of imatinib. Of course, nobody can forget the contribution of Dr. John Goldman, who gave new directions to the treatment of CML and the way we manage it today with all the molecular monitoring and the TKI therapies. And because of these efforts of all these stalwarts, this tablet Gleevec found its space on the Time magazine cover, where the presidents and heads of the states of various countries vie to get their faces on. So while all this is fine, today I will be highlighting 2 more stalwarts who are slightly less talked about in our journey of CML. We all know the success of imatinib and everything. It all started by understanding the very basis of kinases, the enzyme which catalyzes the transfer of phosphate groups and which is responsible for all kinds of cell signaling, cellular metab, protein regulation, transport, and secretory processes. And these kinases could be carbohydrate kinases, protein kinases, or lipid kinases, multitudes of them. Protein kinases themselves can be of various kinds, like serine, threonine, tyrosine. So tyrosine kinase is just one of them. And it is here that we need to recognize the efforts of Dr. Edwin G. Krebs, who did phenomenal work for 3 decades, starting in the 1960s on trying to elucidate the protein kinases. And of course, he got a Nobel Prize in 1992, very rightfully, for his phenomenal work on protein kinases. And just for the students in our audience, we should not confuse Dr. Edwin G. Krebs with this another great gentleman, that is Dr. Hans Adolf Krebs of the famous Krebs cycle fame, the citric acid cycle fame, again a Nobel laureate, but he got his Nobel way back in 1953. That's why you can see the photograph is in black and white. And what Dr. Edwin Krebs' research led to was elucidation of these 92 different kinds of protein tyrosine kinases, as you can see, spread all over the human genome on various chromosomes, divided into 29 different families, 10 of them in the non-receptor families, 19 of them in the receptor families. Each family is having some groups. The very first non-receptor family, that is the Abelson family. And in the Abelson family, the first gene, that is Abelson1, located on chromosome 9q34, is what is our area of interest. Then we've been able to characterize each of the 90 tyrosine. So much so is the importance of this work that now people have said that probably there are no undiscovered tyrosine kinases known in the current human genome. So that is the effect of Dr. Edwin Krebs' work, that we have been able to characterize almost all protein tyrosine kinases. And this is what, when this Abelson protein tyrosine kinase leaves its home on chromosome number 9 and migrates to 22, we get this chimeric BCR ABL1, which of course, as is the common in the native Abelson kinase, where the cap domain is able, with their hydrogen bonds, able to keep the catalytic domain under closed conformation and only open when it is required, so that it binds ATP. When this cap domain is replaced by the BCR part, this function is lost and we get a constitutionally activated or an open conformation BCR-ABL. And this leads to dysregulated tyrosine kinase activity and the pathogenesis. My aim today is not to go into the details of, there is very basics, but just as a recap for us to get the things in perspective, how this disease used to be inexorably from a chronic phase to accelerated phase to a blast crisis, inevitably having a survival of only about 3 to 5 years in an untreated. And just with this one TKI inhibitor, how life has changed. When it binds competitively with the ATP and does not allow dysregulated protein tyrosine kinase to allow tumor cells to proliferate. And this is what imatinib did. The first ever, this is the IRIS study. You can look at the huge gap when imatinib was first compared with combination of interferon and ARA-C. And over the period of years, we have recognized that with the various TKIs, starting with imatinib and so many other TKIs, the life expectancy has almost become like any other normal human being. So a person with CML leads a life just like any other person of his age and sex, and even with various comorbidities, as was elucidated by Sossel in Blood 2015, that a person with CML and other comorbidities is more likely to die of his comorbidities rather than of CML. And that is where the long-term outcomes of this is the IRIS study, which further in 2017, they gave a 11-year follow-up of the IRIS patient. If we concentrate here, I'll just get the laser pointer. Almost around 92 to 93% patients who had achieved a molecular response who continued on imatinib. These are of course, the survival curves. So this is a study which was done by one of our own patients one of my own students in FMC Pune, who was an MD medicine student, and he analyzed our data of around 103 CML patients, and he also found this is absolutely people taking generic government supplied imatinib, something which we used to get for, even now we get for 18 rupees a tablet. That's a government supplied, and most of the people would think that, and the rates of MMR, as you would see, is almost comparable to the Gleevec as mentioned in the IRIS trial. So irrespective of what kind of imatinib we use, this is again a Polish study, and they also saw that over a 20-year follow-up, after 15 years, people who did continue imatinib, their survivals or their rates of MMR was in the range of 80s to 90%. Same story with nilotinib. So although they did show a difference between imatinib and slightly better with the nilotinib, the bottom line was overall survival at the end of 10 years is not very different. After 10 years, whether a person is taking nilotinib 300 or nilotinib 400 or imatinib 400 mg daily, it's almost the same. So it's essentially the success stories of various TKIs. We are not here to discuss whether it should be imatinib or dasatinib. That is for a different day, and there have been n number of talks on upfront dasatinib or nilotinib or imatinib. The idea is that such a fantastic result is because of TKI. So on one hand, we say that this has given us a phenomenal success. So the moot point is, on a Saturday afternoon, evening, or a Saturday night, why should we be discussing discontinuation of such a successful treatment? I like this tagline, CML. With great success comes great responsibility. Also, although this is a tagline which has been taken from Spider-Man 2 movie, but is actually from Atharva Ved, from which they have borrowed this tagline. So it is the physicians, us hematologists, who have achieved great success, and now it is our responsibility to take it forward. So if we tell a patient that when a CML is diagnosed, that he has to take lifelong or an indefinite therapy, what are the perils? Of course, short-term, drug toxicities, all the cytopenias, pleural effusion with dasatinib, some cardiovascular events, there will be their skin reactions, but there'll be a number of long-term effects. There's short-term effects will all settle down, but long-term effects will persist or they may appear later. These TKIs may enhance overt or subclinical medical condition, underlying medical condition. So a person who is not yet manifested his diabetes or his CAD may manifest. It interferes with good quality of life because of ongoing these nagging toxicities. Then, of course, indefinite therapy has its own cost, not just the cost of the drug, the cost of regular monitoring. Even if it's a CBC once in 3 months, an LFT, RFT, that has got a cost. Physician consultations. And if these patients do get complications of therapy, it could just be a skin rash and the person has to go and consult a dermatologist. That has got its own cost. For me, the most important thing is psyche. You tell a patient that, try telling a 35, that's the average, 35 to 45-year-old people who get CMLs. Try telling him that for the rest of the life, he has to take this medicine, 1 tablet imatinib, and he'll be fine. The mental fatigue it will cause, whether he'll be compliant or not, and his outlook towards his own life about the disease. And that is where I come to the second less talked about great person as far as CML is concerned, Francis Xavier Mahon from France. And we'll be coming later on to his discoveries, what he did. Before that, we just go through our TKI side effects. So this is what the guidances are, standard guidelines, that if a person is having one of these various comorbidities, what is the best TKI to choose? Basically, these guidances have come because we are aware that if we want to start a person on nilotinib, there are some absolutely red zones that a person with a prolonged QT interval or a cardiac failure should not be given because it will exacerbate. Even other patients with hypertension, past history of CVS should be better avoided on nilotinib. Similarly, a person with a pre-existing pulmonary condition or a gastrointestinal bleeding should avoid dasatinib, so on and so forth. So almost none of the TKIs have got all green. Everybody has got some yellow or a red thrown here and there, basically telling us that not a single TKI is safe in all the subset of our patients. This is a large German study of 10 years survival of patients. That was a CML4 study, which they studied around 1,536 patients and divided them, randomized into various groups, IM 400 alone to IM 800 to IM in various combinations with interferon or ARA-C. And again, that they found in their cohort that there were a total of 275 deaths. Although if we take out the deaths because of transformation, so about 100 odd deaths did take place to transformation to AP or BC or infection. But if we look at these deaths which are not related to CML, so there could be probably related to the therapy, whether it is second malignancy, whether they are cardiopulmonary, whether it is renal insufficiency, or a whole host of unknown deaths. Again, IRIS 10-year follow-up in 2017 reported drug-related serious adverse side effects in which it had to be temporarily discontinued. There were, of course, a small number, but then there were some patients who did have adverse events big enough to merit discontinuation of therapy. NS10D 3-year follow-up again has shown us the various the side toxicities, both related to nilotinib as well as imatinib. And so much so that the ELN has come out with recommendations for management and avoidance of adverse drug reactions while we are treating patients with. So this ELN recommendation, just I am showing a representative chart from this about liver toxicity, but it's a very beautifully written document as to each and every how drug toxicity has to be managed. If we go to, these are all part of clinical trials, what I just showed. But if you go to the public domain, drugs.com, where patient reported, physician reported things are collated very systematically. Every drug has a page. And if you look at side effects of imatinib, the small font only represents that nothing can fit into one slide. So many of them, they have divided into common, uncommon, and rare, and almost every system is affected. What I am highlighting from this is adverse drug effects reported in more than 30% of the patients, and they were these dermatological, gastrointestinal, hematological, musculoskeletal, and so on and so forth. What I have highlighted in red is what my student Dr. Aditya's thesis. These were something which we also had noted in our own study of 103 CML patients, which was Dr. Aditya's thesis. And of course, we could not find much of headache and upper respiratory infections and insomnia and depression in our patients. But yes, there were a lot of overlaps. So having said that, these are all reported side effects and they're significant numbers. Now, amongst these adverse drug reactions, some of them will persist either beyond 5 years or they may crop up for the first time beyond 5 years. So that is the problem of a long-term TKI therapy. So it could be a dermatitis. For me, as a CML physician, the biggest problem is gastrointestinal. Almost 30 to 40% of my patients do complain of one of the dyspeptic symptoms, whether it is nausea, abdominal pain, or some musculoskeletal pain. And how we counsel them is that probably this is the cost that they are paying for being in remission. So we tell them that till about 20 years ago, when there was no imatinib, people used to have a median survival of about between 3 to 5 years. Today, 15 years, you are continuing this drug, you'll have to live with these muscle spasms, cramps, a little bit of diarrhea. Fine. So it's a cost you have to pay for living with your disease and being in remission. Now, this is a little bit of a concerning thing. Imatinib long term, especially when we continue imatinib for more than 10 to 15 years, has been systematically found to reduce GFR in not one, two, but multitude of studies. So much so that this Brazilian study estimated that the GFR reduces by about 2.7 ml per year. And this is again a paper from Dr. Portis's group, which again they documented a drop of GFR both in terms of ml per minute and from the patient's baseline once the person was on imatinib. And as you would see, as compared to dasatinib and nilotinib, the drop in GFR was maximum with imatinib. So with all these adverse effects, it's not that people did not think about stopping imatinib earlier. It is not that suddenly in 2020 or in 2018, we have woken up and we are talking about trying to stop imatinib. There had been case reports way back in 2004, 2005, but all of them showed that if you stop imatinib, the person will relapse. So this is the conclusion of this, that there were these 3 patients and all of them relapsed when they tried to discontinue, and all of them discontinued imatinib because of the various adverse effects. Herein comes Dr. F.X. Mahon. When everybody was trying to tell us that you stop imatinib and the disease will come back, Mahon created a pilot study in which he stopped imatinib for 12 patients. And out of 12 patients, he showed that 6 of them, that is 50% of them, continued to remain in cytogenetic remission even 12 months to 15 months after stopping imatinib. Was it just a bravado? No, it was based on absolute scientific logic. Why? Because Dr. Mahon had reasoned out that patients post BMT in the pre-imatinib era, even when they were in CR post BMT, some of them continued to show some residual BCR-ABL transcripts, but they were otherwise in absolutely, they were off all kinds of drugs. Even their post BMT immunosuppression had stopped. They were leading a normal life, but their BCR-ABL showed some minor transcripts here and there positive. Some of them presenting as late as 18 months post-transplant, a BCR-ABL transcript coming on and persisting. So he realized that just a mere presence of BCR-ABL does not mean clinical disease. Then his own study, when in the interferon era, where patients, because of toxicity of interferon, had to stop, in his 15 patients who had stopped interferon, 7 of them continued to remain in complete cytogenetic remission. And that is what prompted Dr. Mahon to go for, after his success of pilot study, to go for his first ever STIMS trial, that is top imatinib trial, in which 100 patients were enrolled whose imatinib was stopped. And of course, they had been in a deep, there was criteria laid down. They had to be on imatinib with minimum 2 years of being undetectable molecular BCR-ABL transcripts. And what he found, overall, around 40 to 45% maintained their major molecular remission, even years after completing, stopping their imatinib. And of course, these were the subgroup analysis of people on prior interferon doing better than those who were not on prior interferon. Surprisingly, they found males to be responding better than females. Imatinib, of course, this is the most significant. If the duration of imatinib therapy was more than 50 months versus less than 50 months, they had a higher chance of maintaining their molecular remission despite being off drugs. And of course, SOCAL scores. If a person had a lower SOCAL score, his chances of being in molecular remission of imatinib was higher than being in high SOCAL score. And this was a follow-up study of Dr. Mahon, in which he said that it was not just a flash in the pan. This continued the persistence of being in molecular remission up to 10 years after stopping imatinib. So they had found there were 4 deaths in their STIM study of 100 patients. None of these 4 deaths were related to CML progression. 1 patient died of pleural mesothelioma, and the remaining 3 TKI, the patients died because they discontinued TKI because of worsening diseases. And there was, one of them had cerebral hemorrhage, one had metastatic gastric adenosis, and one had an ARM. So none of them died because his TKI was taken off and he died of progression to AP or BC. Now, Dr. Mahon, of course, has started his STIM2, still ongoing study. The preliminary reports were published. This is for de novo patient. The previous STIM study was on people who were on Ara-C and had switched over to imatinib. This is a STIM2 study. 124 patients are being taken on that. Results are final, are still awaited. And interim analysis said that there were around 43 patients or 44 patients who had to be restarted on imatinib because they had lost their molecular response. And the immediate takeaway point was that everyone who was given a TKI re-challenge became back to they had regained their major molecular response. So after Dr. Mahon's studies, of course, he was the pioneer, but he was not the only one. If you can see, look at the numbers. Large number of studies have taken place, in fact, ranging from small studies of 15 patients to larger studies of 750 patients, multi-center, multi-institutional, multinational studies. And almost all of them are reporting a TFR rate ranging from the lowest from around 40s to higher side being close to 70%. So whether we are in 40% or in 70% is not the question. The fact is that there is a substantial percentage of people who can be kept off therapy. And this is a same representation of that in a graphic manner, the TFR rates, and the dots indicate the various studies. If you see, if we draw a line somewhere here at around 50%, most of these studies would lie at around 50%. So we can say safely that 50% of the patients who do get into the TFR trial will maintain their molecular remission of their TKIs. Of course, there are certain requirements. This is a well-known chart that there are criteria which have to be considered, whom to consider for TFR and whom not to consider for TFR. And based on this, we started our own study in 2017. This grant was given to us from the Armed Forces side. That is, we have an Armed Forces Medical Research Council based in Delhi, Ministry of Defense, from which yearly we get grants. So this was a study which we registered on the NCT website, and started in 2017. this phase we continued till about 2019, and I'll just show you. We did an extension study thereafter. This is it was when I was in Command Hospital, Pune, that this study was approved, and this was an interventional, no masking, unblinded study. That time we had thought of enrolling around 25 patients. Finally, we landed up extending by another 12 patients here in Lucknow because we made it a multi-center study, and our patients' age ranged from 18 to 80 years. There were 11 females. Our minimum mandatory requirement was imatinib duration of 7 years with undetectable residual molecular, that is UMRD, undetectable residual disease, for at least 2 years prior to recruitment. This almost translates to MR 5.0 or 4.5. We started the study in July 2017, and the last patient which was taken up was on 9th of March 2022. We've been doing monthly qPCR for 210 transcripts for 6 months, then post-stopping therapy, then 2 monthly for 6 months, and then 3 monthly for 12 months. Our trigger, as per our protocol, to restart imatinib is loss of major molecular response, or if the patient wishes to restart because of his own anxiety. Our interim, the details I will be telling because still not done the statistical analysis in the MHE meeting, which Dr. M.B. Agrawal has kindly invited me to give a deliberation on 29th of January. By that time, all the statistics and the graphs would be ready. But as of now, we know that out of our 37 patients, 17 of them have had a molecular relapse in which we have to restart imatinib. And these other 21 patients are still continuing without drugs. As we said, from 2000, there are some patients from 2017 to as recent as 2022. Each of these 16 patients has regained their major molecular response. Time to regain has between 2 months to 5 months. 7 of our patients did have a TKI withdrawal syndrome, that is, insomnia immediately within 1 to 2 months, musculoskeletal pains, insomnia, and so on and so forth. Off-record complaint, because it is not there in our proforma, but many of our patients, especially ladies, they have suddenly started complaining that they have darkened, or they have become, they've lost their fairness. So of course, but we have recorded as an off-record complaint. This is how a typical our monitoring looks like. A patient with various dates and the BCR-ABL transcripts. We make sure that the Abelson copies are in excess of 50,000. And of course, this is a kind of graph which we see in patients who have a fluctuating BCR ABL level, and this is a trigger. So like in this particular patient, when it crossed 0.16, we started his imatinib, and if you see the date here this is one of our recent patients in whom we had to restart. On 8th of August, 20th of August, we diagnosed him, and on 1st September, he restarted his imatinib. And on 23rd of December, that is just about a week ago, he had again regained his molecular remission. So this has been the story for all our 16 patients. So the challenges which I faced in the last 7 years, why I'm saying 7 years is because this project was envisaged in 2015. And it took me 2 years to just get in institutional clearance. It was almost a fight in the ethical committee meeting where the ethical people would not allow me to go ahead with the study, saying that how can you stop a medicine for a cancer patient? What if the person dies of cancer? They are not ready to listen to all the data which I'm showing you. He says, no, don't tell us European data, tell us Indian data. I said, there is no Indian data. Probably this is the first Indian studies. He says, then why are you doing? I said, somebody has to be creating the first Indian data. Otherwise, it's only American, European, Australian, Japanese, everybody. If Japanese and Koreans and Brazilians have done TFR, why can't we start a study? So anyway, it did take a lot of convincing. It took about a year. There, of course, then I got a funding in 2016. After that, all the documentation work had to be done to start a clinical trial, the patient case record forms, the consent forms, and so on and so forth. And then it took me almost 6 months to set up a monitoring facilities where we were guaranteed a MR 4.5 to 5 in terms of Abelson copies, because once we stop imatinib, we cannot be thinking of a lab report in which we do not get a guaranteed MR 4.5 or 5 report. Then, of course, second is the patient perspective. Counseling. Patients and relatives have to be counseled in great detail. The patient information sheet which we have should be in the language which he understands. So I had translated it in Marathi as well as in Hindi while I was in Pune. And the consent form, we used to give it to the patients and used to tell them to come back after a week. So it is not that the person comes here and he has to sign the consent right then and there. He goes with the information and comes back after a week, and then he signs the consent form, after which we would stop his imatinib. We had to go into the details of travel arrangement, because in armed forces, most of our patients, they come from slightly far off places. So of course, by the way, the government of India has got, it's nothing which I had to do out of the way. All cancer patients have got a facility of availing free travel by train on AC3 as well as sleeper class with confirmed reservation. All that the doctor has to do is on a prescribed railway form, sign and give the form to the patient, and he will get his free railway ticket up and down from his hometown to the hospital, up and down, both ways, along with one attendant. And same goes for the Maharashtra had done for the bus services also. So we went into these travel arrangement, compliance with monitoring. We had to make sure that the patient would come for his monthly BCRA bill. We used to take not one but two telephone numbers, one of the patient and one of his relative. So if he did not turn up for his monthly or a 2-monthly monitoring as was desired at that time point, he would be given a phone call by one of our person who was a part of the team who was doing the follow-up. And then of course, managing anxiety of the patient. There are other side of the patient where patient would be very anxious that what if my disease relapses? The moment they will see 0.0014, they will think that my disease is coming back. Laboratory issues. Now, this is a thing which I faced in Lucknow, because in Pune, we had our own FMC lab, which was standardized. But when I came here in Lucknow, we had to rely on an outsourced lab. Again, NABL, CAP accredited, no confusion about the quality of the lab services. But then there were some random outlier values, and I'll be showing you in the next slide what I'm talking of, a random outlier value. Conflicting. So this patient goes and gets a test done from SGPGI, which is again a very reputed lab of our country, a national level institute. And they were two absolutely. One is showing a BCR-ABL of 0 or an MR5 level, and the other is showing a BCR-ABL of 0.18. So we repeated from both the labs. Again, this lab continued to show 0 and this lab continued to show 0.17 or 18. So conflicting report. Then, of course, cost of monitoring when it is outsourced. Patients have to pay for it if it is not a part of a trial in which everything is being funded. And miscellaneous. This is, 2 or 3 of my patients, they started the imatinib on their own when they got anxious. And they had to be told again to go that either they get it out of the trial, or at a 0.001, they should not be starting their imatinib. But then by that time, they had already taken 1 month imatinib from their local pharmacy, because in our country, it is very easy to get imatinib without any prescription. So this is what I was telling you about an outlier report. So this lady, she happens to be one of our doctor's wife, very elderly. She's 80 years now. And because she has hypertension and diabetes, and there was an issue about her rising creatinine after 10 years. So I started her therapy in way back in 2010 when I was in Delhi. And here now she's settled in Lucknow, and she came to me in 2020 September. And I said, in August, we said we'll stop, because all her BCR-ABLs were 0 for the last 10 years almost. So we'll stop your imatinib. We stopped. The very next month, her BCR-ABL comes 12.3. Now, this was amazing. In 1 month, you normally don't get a BCR-ABL of 12.3. So, but with this report, I was forced to restart. Very next month, if you see, on 16th of October, this 12.3 again comes down to 0. This is this report on a 150,000 Abelson copies, 0. So Probably this was an outlier report, but by that time she had already restarted her imatinib. So my take on TFR on Indian patients is we have a population which is got a younger age of onset. We typically see in the 4th and the 5th decade. So asking a 35-year-old or a 40-year-old person to take a drug lifelong is slightly, demanding for the patient psyche. Large number of our lady patients are women of childbearing potential. And we need to keep in mind that all the TKIs are teratogenic. Incidence of hypertension, India is known as the diabetes capital of the world. So we have a higher set of populations in which there is a long-term chance of a renal toxicity. Most of the patients pay out of the pocket. So even if we consider 2,000 rupees per month of imatinib cost, they are paying close to 25,000 rupees per annum for their cost of therapy. Whereas the cost of monitoring, I'm just taking this figure 10, monthly into first 3 or 4 months, then 2 monthly, and then 3 monthly. In 2 years, we'll be doing about 10 BCR-ABLs. Today, it is openly available at 2,000. Core Labs does it for 2,300. Lal Labs does it at 2,300. Most of the labs will do it at around between 2 to 2.5 thousand. So 22,000 is the cost of monitoring over 2 years. It is less than 1 year's cost of their drug. And most importantly, we as physicians need to convince our patient that there is no concern about not regaining MMR with TKI in case of recurrence. How to go about it? I think just like when we see a myeloma patient, we say transplant eligible or transplant ineligible. And then we decide our therapy based on which side he's going, whether we are going to take him up or not. I think we have to have the same mentality. When I see a CML patient, I see TFR eligible, TFR not eligible. And then if he is a TFR eligible patient right from day one, I don't tell him that he has to go on a lifelong therapy. I say, you have to go on a definite therapy, maybe 7 years, maybe 8 years, but there is a definite therapy, probably. And if you stick to your therapy very much, there is a big likelihood, maybe 70-80% likelihood that we will be able to take you off from your therapy. So then the patient is also motivated and that improves his compliance to go around with the drug. And we tell him right in the beginning that if he, falters with his therapy during these initial 5 to 7 years, he may lose his opportunity of going for the TFR because he may not achieve a desired monitoring goals. And thirdly, what most of the studies have found that early molecular response will lead to a higher rate. So it is not that now with second generation TKIs generic being available at almost equivalent cost to imatinib, I would say an early molecular response to be started with a 2G TKI, and a year later when a person goes into a deep molecular response, and if the cost is prohibitive, or maybe with the dasatinib, I would not like to risk pulmonary arterial hypertension, maintaining the person on imatinib for the next 3 to 5 years in those patients who are willing, maybe a way forward, especially for ladies of childbearing potential. And this is a study which just shared that whether we start a person on imatinib, this is the only randomized study in which compared dasatinib with nilotinib. There's absolutely no difference between whether rates of MMR, MR 4.0, 4.5 between dasatinib and nilotinib. Eventually, TFR eligibility depends on early molecular response, deep molecular response. And if we can assure that for our patients, we've got. So my concluding remark would be that a TFR in Indian patients is possible as a standard of care in carefully selected patients. This number can be as high as 50 to 60% in all patients who may be eligible. And even considering that, let's say 50% of these people go into sustained molecular remission of imatinib, it means 25% of our patients can be taken off a therapy which is potentially toxic, which is potentially going to damage their kidneys, which is potentially not going to allow them to have a family in case it's a young woman. Thank you so much for your patient listening. And I end my talk here.
Thank you so much, Sanjeevan, for that very thought-provoking talk and your personal struggle in setting up the system of TFR in your institute and your experience and the work of your students. It was really something very stimulating and the first of its kind, as you told us. There will be many, many people probably today listening to you, and there will be many followers giving the benefit of what you've done to their patients. So for a while, we will just see another talk from me, and then we will have the question and answer session. So in life, there are two sides of the coin. And what you heard just now was the brightest aspect of chronic myeloid leukemia, something which keeps you so happy. But then the other side may not be that rosy. Which side your patient will go to is unknown, though we were told about the predictors just a few moments ago. Now let me just show you this cartoon. So whenever newly diagnosed chronic myeloid leukemia, there are a small percentage of patients who do not only have an aggressive chronic phase, but are presenting with blast or accelerated phase. Once you put them into therapy, there is a group of patients who do not achieve this requirement of deep molecular response. And then there are these, as we just heard, 40–50% of patients who, when we try to put them into TFR, they relapse, they recur. As a result of which, those presenting with blast crisis, those not achieving DMR, and those getting recurrence of their disease is a huge unmet need of the hour. From 1865, Fowler's solution, to 2010, ponatinib, we have come a long way, and it's a huge success story, which you just heard in the last 45 minutes. And if it was not for these two compounds, the ponatinib and the asciminib, probably I wouldn't have been talking to you. And the rest of my talk will revolve around what we have achieved in last 12 years. So the unmet need in the management of chronic myeloid leukemia in third line and beyond is the topic of my talk. And by later lines, CML, which looks to be a beautiful disease, a very innocuous disease like a rabbit, gets the teeth and it becomes a bad cancer. My talk will be in these 6 divisions. And the first one is the unmet need with respect to the response of TKI in the subsequent lines. This is a very familiar cartoon in which when we start a patient on TKI, we look at the response at the molecular level at 3 months, 6 months, 12 months, and we have these criteria by which we say that the response is optimal response, there is a warning that things are not going so rosy, and there is a failure of response where you have to quickly change your TKI. Either because of the intolerance or because of this kind of failure, you have moving from first line to second line. Your patient was a imatinib, dasa, nila, or bosutinib. You have the options, which are relatively easy. But when you start moving from this second line to the third line, the things start becoming difficult. So much so that you find the stem cell transplant as an option over there, and probably the practical option in India for many patients who are transplant eligible, who have the funds, who have the donor, and who have an access to a good center. However, challenging this approach are these 2 compounds, the ponatinib and the asciminib. The outcome of a patient who fails 2G TKI is far from satisfactory, and all of you who are present over here as faculty and those who are listening have seen this in your practice. There are a number of studies listed on the left side, and if you look at the overall survival of patients who have moved to the third line of therapy, it is reasonably dismal. Whether you're talking about event-free survival, TFS, FFS, or overall survival, the curves are no more those horizontal curves that we are used to showing our students in CML. Not only that, depending upon whether your patient is in the second line, third line, or fourth line, the overall survival keeps dipping. If you have not had transformation of the disease to blasts, these curves may be a little better, but still they are dipping with each line of therapy. The next question that comes, can you predict how your patient will respond when you have to move from the first line to the second line? And there are a couple of studies which I would like to show you. And this one is from Goldman from Europe. And there are 3 predictors on the basis of which he created this Hammersmith score. If you had bad cytogenetic response, you get a very high score. To start with, if you had a high or intermediate Sokal group, you get a high score. And if you struggled by giving the TKI because of recurrent neutropenia of grade 3-4, which very often resulted into you stopping or reducing the dose of imatinib, you get a higher score. And based on this score, you have the response in the form of complete cytogenetic response to the second generation TKI. Higher the score, poor the response. Lower the score, better the response. Then this is the US study from Cortes and his group, where they just took 2 risk factors. One, lack of any cytogenetic response to the first line TKI and the performance status. And based on that, they showed that there could be a risk stratification with respect to the response. Lancet published this long ago, risk assessment of patients with CML before bone marrow transplant. And those of you who are transplanted are very well aware of this. The score, higher the score, worse the outcome. So if you have a matched unrelated donor, if you have a patient in accelerated phase or blast crisis or second chronic phase, if your patient is beyond the age of 20 or 40, if it's a female donor to male recipient transplant, and if this transplant is after 1 year of the diagnosis, then the outcome is bad. The 5-year overall survival for very high score is just 22% versus 0 score when it is 72%. So that just gave you the bird's eye view of that how bad the scenario is when you have to move beyond the first line and the second line of treatment. Then the question of tolerability to these TKIs. And Dr. Sanjeevan showed you a number of problems. Besides primary resistance and acquired resistance, you have this pan intolerance across all the TKI of 5 to 10%. And you and me have seen this in practice, where you just get exhausted with the TKI and the patient cannot tolerate them. And then the problem of adherence, which very often goes unnoticed, but is a huge problem. All this leads to patient resulting into blast crisis, which, as you know, is a death sentence in 90 to 95% of patients. What are these intolerances due to? These intolerances are all due to off-target effects of the kinase inhibitors. And as you know, the various TKIs have large amount of off-target activities because of their targets. And look at this kind of picture. I don't want to describe this, but there are 20 toxicities and you've got so many pluses in front of each of the TKI that it is a bit amazing how our patients keep taking these compounds. Imatinib has its own side effects, nilotinib, dasatinib has their side effect, ponatinib, bosutinib has their side effects. And there are these common effects of myelosuppression, electrolyte disturbances, and liver toxicity. This TKI intolerance ultimately leads to discontinuation of the therapy. A number of studies have shown this, that the figures can be quite alarming. And therefore, you select your TKI based on patient or the host profile, knowing the side effect of a particular compound. And if there is an occurrence of that, or there is already a pre-existing problem, you avoid or choose a particular TKI. Moving on to the third issue, and that is the development of TKD mutation in the resistance. So how big is the problem of the TKI resistance? 5 to 10% of CML patients have primary resistance. 20 to 30% develop secondary resistance. And 5% of patients just progress to the blast crisis or accelerated phase. And you have huge number of very important references over here telling you that about 60% of acquired resistance out of these is in the able kinase domain. When you use TKI in a sequential fashion, imatinib followed by nilotinib, followed by DASA or BOTU, there is an emergence of new mutations. And there are various studies. Once again, this one is from Curtis from US, showing you the localization of the mutations in imatinib-resistant CML prior to starting the second TKI. And the worst enemy, the 315, has an alarming incidence. And here you have 250 having another higher incidence. So some have less incidence, some have more. There are so many mutations which occur, and the basis of which you have to choose your second generation TKI. And this is localization of the mutation following the second TKI. So when you use nilotinib or dasatinib as a second line treatment, you get new mutations. And of course, the previous one may be lost. This gives you an overall effect of the second kinase inhibitor on the development or regression of these mutations, depending upon which drug have you used as the second line, DASA or NILO, etc. So KD mutations after therapy with the second generation TKI, again from Curtis, all these darker ones are the new mutations. All the bright blue color are the mutations which are persisting. So sequential treatment with different TKI leads to more and more new mutation is the summary of these presentations. And this is once again the relative frequency of the BCR-ABL kinase domain mutation detected in number of patients, and you can again see 315 at the top over there. So some of them are more than 10%, and 315, which is a bad mutation, is over there. Now for some of these mutations, besides 315, your 248, 255, and 315V, there are very limited options available to you, especially in India at the moment, because these are very highly resistant mutations. How do you pick up these mutations? By two of the techniques, either Sanger sequencing or NGS. And what's the comparison between Sanger versus NGS? NGS provides a more accurate picture of these mutation status. And this was published 2 years ago, again in Blood. Sanger sequencing picks up about 25% of mutations, as against NGS, which picks up almost the double. And some of these can be very, very significant because you pick up mutations which are resistant to anything that you're going to use after that. Once again, over here, one mutation probably both can pick up, but two mutations, it's the NGS which is going to pick up. So this kind of compound mutations can be picked up only by using NGS technology. And the next in CML study is the prospective assessment of the NGS detectable mutation in CML with non-optimal responses. The summary of this article was, NGS detects low-level mutations, both in Sanger sequencing negative and in Sanger sequencing positive patient, and gives you the accurate picture of the mutation status, including those compound mutations. The TKI resistant low-level mutations are invariably selected if the patient is not switched to another TKI, or if they are switched to an inappropriate TKI or an inappropriate dose. So the lesson is that you should resort to NGS. However, there are pros and cons. Sanger sequencing is widely available, easy to use. And there are disadvantages because it has got low sensitivity, low discovery power, not as cost effective if you have a large number of samples, etc. NGS is more sensitive. It is unable to scan the entire KD for any mutation. This higher discovery power, ability to identify novel variants, higher mutation resolution, more data with the same amount of DNA, and enables clonal analysis in case of multiple mutations falling within the same sequence. But it's not widely available. It requires that you have a pooling of 8 to 10 samples to make it cost effective, labor intensive, not yet standardized, and so on. The fourth point is the unmet need of quality of life and economic impact. In patients with CML, the quality of life worsens by increasing the disease stage and by increasing the line of therapy. Has been published, researched. So this is quality of life as measured by a validated FACT leukemia scoring system. It was significantly lower in patients who moved to accelerated phase of blast crisis. And similarly, it is significantly lower in patients who are getting second line of therapy or third line of therapy. At the same time, the cost increases. If a patient is not doing well with the first line, has to move to the second and third line, the cost significantly increases, has again been researched and published. I come to the most important aspect of my presentation, and that what is the current management option and the newer therapies that you have when your patient has entered the third line of treatment. So first of all, there is no established standard of care for patients who have entered the third line. You've used imatinib, you have used either of nilotinib or dasatinib, and their failure tells you that the next second generation is not going to give you a good outcome and you want to do something more. And what is that something more is not the standard of care. In a retrospective study of patients treated with first-line imatinib followed by either dasatinib or nilotinib, shows you that the overall survival in 5 years decreased to 82% and 77% respectively. Available TKI treatment options by the line of therapy, we have seen this when I began my talk, starts getting reduced. And by the time you come to the third line, you are left with very few agents. And there enters ponatinib. If you look at the mechanism of action of these drugs, as far as bosutinib or other first and second line TKIs are concerned, they inhibit the BCR-ABL kinase by competing with ATP by binding to the ATP binding site. And a drug like bosutinib also inhibits the SRC family kinases. But it does not have the activity against 315. When you come to ponatinib, it competes with the ATP and inhibits the BCR-ABL kinase via the ATP binding site. However, it has high activity against cells expressing 315. And that's a huge asset of ponatinib. It also inhibits various other kinases. And that's important from the angle of adverse effects of ponatinib. The second most important compound in this group will be asciminib, which is called STAMP inhibitor. STAMP is abbreviated form of specifically targets the ABL myristoyl pocket. That was the ATP binding site where imatinib, dasatinib, nilotinib, bosutinib, ponatinib act, and that is where the asciminib works. Entirely different pocket. So asciminib is an allosteric inhibitor of BCR-ABL1 that specifically targets ABL myristoyl pocket, the STAMP. and therefore it's called STAMP inhibitor. It does not compete with ATP. It is thought to be more selective than all other ATP binding competitive TKIs that inhibit numerous other kinases. And that's the plus point, that it is many fold safer than a compound like ponatinib, because it does not inhibit large number of other domains. It is effective against 315. So you've got two compounds for 315, ponatinib and asciminib. And overall, it is expected to have very few adverse events as compared to ponatinib. So patients with CML-CP who have failed on 2G TKI usually do not benefit by introducing another 2G TKI. The phase 2 PACE and OPTIC trials evaluated ponatinib in this situation. In the PACE, the patients who were resistant or intolerant to the second generation TKI showed that ponatinib can achieve deep, durable responses, but at a huge cost of markedly increased arterial occlusive event. To nullify that, you have this OPTIC trial where the dosing of ponatinib was response-based. As a result of which, it showed that it is possible to treat these patients with ponatinib with reduced incidence of arterial occlusive disease. So this is the design of the study. PACE and OPTIC. Will not go into the too many details, but 98% of patients had received 2 or more second generation TKI, 60% had received 3 or more, and 97% of patients were resistant to 1 or more prior second generation TKI. And these patients had various kind of best possible responses earlier, and what you achieved will be seen over here. Both in PACE, where everybody got the full dose of ponatinib, and in OPTIC, where you had multiple arms, 45 tapering down to 15 as maintenance, 30 tapering down 15 as maintenance, or 15 through and through. You have got responses which are worth proud of. So you see over here the comparison of third line TKI after failure of imatinib and dasatinib or nilotinib. So post imatinib and dasatinib shown over here, ponatinib being the best. And this is post imatinib or nilotinib, ponatinib again being the best. So when you come to the third line, giving another second generation TKI is poor medicine. This abstract, which was presented orally in ASH, gives you the objective study design, key results, etc. I'll just show you what I've put in the red. So the design of the study was there were 3 cohorts, 45 milligram, tapered to 15 after achieving the response, 30 tapered to 15, or 15 through and through. The best results were achieved when the starting dose was 45 and it was tapered to 15 once the response was achieved. So the conclusion was the clinical benefits of ponatinib were there across all the 3 dosing regimen. And this supports the use of ponatinib as the third line treatment in resistant cases, regardless of the baseline disease burden and regardless of whether there is 315 mutation. And the OPTIC part of the study also tells you the way should be 45 to be tapered to 50. So that was ponatinib. The treatment that we often use in this country is bone marrow transplantation. And this study is to look at the optimum timing of the allo-SCT in CML in the TKI era. Looking at the residual life expectancy. And if you look at this stem cell transplant versus TKI, the results with respect to residual life expectancy are better with TKI in CP1, CP1 with 1 TKI, CP1 with 2 TKI, CP2. But the moment you move to the accelerated phase in the blast crisis, your results of stem cell transplantation matching or being superior to TKI. This is MD Anderson data about the outcome of allotransplant after TKI failure. If the transplant is done in the chronic phase, it gives you better results than in the advanced phase, both with respect to event-free survival and overall survival. We come to now asciminib. So asciminib is the phase 3 open label randomized study, the STAMP inhibitor versus bosutinib in CML after 2 or more prior TKI. So it could be imatinib plus dasatinib or imatinib plus nilotinib. Bosutinib was used as the comparator arm and not ponatinib, because when this study started, no one knew what the dose of ponatinib should be, 15, 30 or 45. So these are various aspects of the study. Again, we'll not go into the detail. There are 2 arms, asciminib 40 mg BD versus bosutinib 500 OD. The groups were quite matchable with respect to the age, female, prior lines of TKIs, the patients having BCR-ABL mutation, and the reason for discontinuing the last TKI. Once again, whether they had received imatinib, nilotinib, dasatinib, etc., were all matched. So there are the results. The discontinuation rate with bosutinib was almost double than that of asciminib, 42 versus 77. And reason for discontinuation, if you look at lack of efficacy, it was 23% with asciminib versus bosutinib, 30 to 35%. If you look at the adverse events, the difference was huge, with very little with asciminib and quite high with bosutinib, 5 versus 20. If you look at the MMR rates at week 24 and week 48, the difference was 13% in bosutinib versus 25%, 13% versus 29% in the asciminib. This treatment difference increased by 12.2%. This is once again graphical presentation of bosutinib versus asciminib with respect to MMR. And if you look at the MR4 and MR4.5, once again, bosutinib, the blue versus asciminib, the green, 4 and 4.5. If you look at the adverse effects profile of asciminib versus bosutinib, it's not significantly different. It gives the details of that. There is a Japanese subgroup analysis of assembled study, once again showing you MMR 30.8%, BCR-ABL less than 1, 61%, and complete cytogen response 50%. And now the last part of my talk about those patients who have 315 mutation. So you've got 3 options: ponatinib, transplant, and asciminib. So that's ponatinib or stem cell transplant, showing you the results in the chronic phase, accelerated phase, in the blast phase. In the blast phase, stem cell transplant is superior to ponatinib. In accelerated phase, the 2 match, and in the chronic phase, ponatinib is superior to the transplant. This is asciminib, first in human phase 1 study design. 20 escalating to 200 milligram twice a day in BD schedule, and 80 going up to 200 in the OD schedule. This is the patient characteristics: median age 54, 39% male, ECOG performance status 0 in majority, 1 in 25%, 92% of patients chronic phase, and number of prior TKIs was 1, 2, 3, 4 in 17, 30, 34, and 17% of patients. And the drugs were dasatinib, ponatinib, nilotinib, imatinib in majority of situations. Now that's the response. MMR, we're talking about 315, remember? MMR 24 weeks 40, 48 weeks 43, 72 weeks 45, 96% 47. So median time to MMR was 12 weeks. 21 of 23 patients who achieved MMR maintained it, and 1% who lost it subsequently regained it. And this is response in the group of patients who received prior ponatinib versus who did not receive. What it shows you that even if you have received ponatinib earlier, you get the response with asciminib in a significant percentage of patients. So irrespective of what drugs, which TKI, how many lines have been used, asciminib is effective in a reasonable percentage of patients. As far as the adverse effects are concerned, you got two of them to be careful about: thrombocytopenia and lipase going up. Not clinical pancreatitis, but lipase going up. Rest all, if you look at the grade 3, 4, they are just 1, 2, 3%. If you're looking at the ischemic stroke, cardiovascular accidents, peripheral vascular disease, cerebral ischemia, it's almost non-existent. So this is the superiority of asciminib versus ponatinib. With that, I stop my presentation. Thank you so much for giving this opportunity and listening to me. And now we will have the question and answer session for both of us, Dr. Sanjeev and myself. And we have got a reasonable amount of time, so we will go quite comfortably. Raise hand sign we will use, and we start with Dr. Krishnaratne.
Thank you very much for excellent eye-opening talk. Now, my question to you, sir, is when you start somebody on second line or a third line, the milestones of monitoring is exactly the same like what you do for the first line, or it's slightly different? You know, the 3 months, 6 months, 1 year. And what is the target? Because I have a few patients who are on second line, but they have not achieved a major molecular response, but you know, the complete cytogenetic response at 1%, and they go on like that. So when they are on second line or third line, you should aim for a MMR. So to repeat it, how do you the milestones of response and you know, the target? Do you really need a MMR or CCYR is sufficient?
Sanjeevan?
Sir, I think we need to understand why we are aiming for these targets. Because if we go for an MMR, the chances of progression to AP or BC is almost zero. In fact, there has been only a single 1 or 2 case reports in which a person on MMR, whereas if we even achieve a CYCR, the chances of progression to AP or BC is just about 1%. So yes, sir, in a second generation, in a 2G TKI, and that too, because we started 2G TKI in absence of response to imatinib, we already know that this person has probably disease milieu, which is slightly not the usual one. We may not be able to achieve an MMR, but if we get a good CYCR, we know that the risk of transformation to AP or BC is just about 1%. And that may be good enough if I am the treating physician.
Yeah, that's what I'm also practicing. So, but
because, sir, exactly, sir, because if I don't get a MMR in a leratinib or dasatinib, I will not push this person towards a ponatinib or an asciminib just like that.
And the milestones, you still expect the 3 months, 6 months, 1 year, or is there any time?
Sir, 6 monthly, because as such, if he's on a 2G TKI as a second line therapy, we'll be doing initially, because I'm sure he would have started with a imatinib resistance upfront or later on. So initial once after 3 months or 6 months, once he has achieved a plateau, it's more a thing. Once he has achieved a plateau, then once in 6 months monitoring should be good enough. Sir,
yeah, absolutely.
Sir, what's your practice, sir?
Absolutely fine. Fully agree.
And sir, we have got none other than Professor Malhotra, who will be, who's done probably the maximum follow-up on such patients, and he can enlighten us.
Sure. So I absolutely agree with what you said, with slight just caveat that if it is due to intolerance, then you are more aggressive. If it is due to failure, then exactly what Sanjeevan said. And lastly, if the patient again has a goal of TFR, because now even after second line of treatment,
Yes, sir.
do keep that goal, then you want further deeper response as much as you can achieve. So those are the only little additions. Otherwise, yes, everything that Sanjeevan said. Hemant?
So I completely agree with that, sir. And thank you very much for two wonderful talks, sir. Very, very happy New Year to everybody. And I'm just a listener, sir. I just like to listen to you two experts, sir. Thank you.
Thank you. Krishna Ratnam, any more questions from you?
Yeah, just one more question. See, somebody is on 2G, and I mean, you said that if they fail one drug, better to go for a third line. But sometimes you have a situation, you do the IRMA, and from one mutation, I mean, they become sensitive to the another 2G. Is it okay to start the another 2G based on the IRMA, or regardless of that, directly go to the third line?
I didn't exactly get your question, but I suppose you asked that if you get a mutation to which your ongoing drug is resistant, then will you switch the TKI? Is that the question?
Yeah. I mean, you do again IRMA if they fail one second generation TKI, and then it becomes sensitive to the different second generation. Say, for example, somebody is on asatinib, and then they're not responded, and then you do the IRMA again, and you have a mutation which is sensitive to nilotinib, for example. Can we just switch to the another 2G, or regardless of that, you directly go to the third generation?
So invariably, you have done the test because patient has failed the second generation. And all my whole talk was based on this, that moving to another 2G TKI is in long term inferior to the option of ponatinib, asciminib, and transplants. So ideally speaking, presuming that you have an access to all these three modalities of treatment, you should choose one of them rather than moving from nilotinib to DASA or DASA to nilo, or playing around with bosutinib, etc. We all do that because of the necessity. There is no ponatinib, there is no asciminib, and not everybody can go for transplant. So you and me, yes. When we fail with two, we go to the third, we go sometime to even the fourth, knowing very well that we are entering an era where the results may not be so good.
Thank you very much.
Sanjeevan, you want to add?
No, sir. Absolutely. In fact, I've got no experience with the third generation. So,
okay, Dr. Stalin.
So, a very good evening, sir. Very nice talks, both of you. Sir, my question is regarding the TFR. So, all the guidelines say that when you attain a DMR for 2 years, the 3 to 4 years of TK duration is fine. But what I feel is, so the more the duration of TK and the higher the chance of getting a TFR. So in a country like India, where what will be the optimal duration for attaining a maximal TFR in our patients? So in your practice.
sir, actually, this is still an evolving field. So all these trials, if you see the STEM trial and all, they were been very, very cautious, and they had a very long duration of imatinib therapy. Now, NSND actually stopped nilotinib with just, so more important for them, more than the duration of TKI, has been the duration of deep molecular response. What they are saying is minimum 2 years of deep molecular response, that is undetectable molecular response, MR5 or beyond, and minimum 5 years. So far they are stuck still to minimum 5 years. But yes, probably it's an evolving field, and I'm sure some trials may come up which may stop TKI as early as 4 years of therapy, but this will be entering gray zone. Right now, I think if we stick to the rule of 5+2, that is 5 years of total TKI therapy and at least 2 years of being in undetectable molecular response. A caveat here is that if we get a early molecular response, like if we have an access to what the 3, 6, and 12 months PCR ABLs were, if those have shown a very good response, then the chances, but that's a different thing. That does not talk about eligibility. That is just our chances of getting a good TFR will improve with that. That is what other studies have done, and if I am able to analyze my data in the next 10-15 days, probably in this small subset of 37 patients, those who did relapse, those 16 of them do relapse. I am not just bird's eye view is I don't have actually there, because earlier some of them are 2004, 2005 vintage. That time most of us CML physicians were not really doing the 3-month and the 6 months PCR ABL so religiously. Now, of course, all of us are doing, but 2005, somebody who got started in imatinib in 2005, and I asked him, show me your 3-month or 6-month data, that is not available. And unfortunately, these are the people who have lost their response.
So regarding the first generation, second generation for imatinib, so you still hold the 5+2 holds good or a more duration of
it's irrespective of the TKI. It is irrespective. Yes, but if we start on a dasatinib or a nilotinib, the chances that he will achieve all these milestones is slightly better than imatinib. It is not that even if you see 50 to 60% of your patients on humble imatinib will go into MMR at the end of 1 year, and 30% of them will achieve a deep molecular response at the end of 18 months. This 30% may become 50% if he were to be started on upfront nilotinib or dasatinib.
Thank you, sir. Thank you.
So, Sterling, I'm going to add a few things. I highly individualize the TFR business. And major criteria are, one is patient's age. If somebody is in 70s and 80s, I don't even talk about TFR.
Yes.
Somebody is in 20s and 10s and 30s, I talk about it very, very vehemently. Second is his tolerance to the drug. If there have been issues and issues and issues all the time, then if I'm comfortable, he has achieved his DMR and he's gone on for 2-3 years, I take a chance to stop it even at 2 to 3 years of DMR. Third is his education status, his monetary status, his ability to come to me from the distance where he's staying. He's staying close by, he's educated, I've developed trust in his compliance. Again, I'm very, very liberal. Fourth is what was his so-called score to start with. And I am one of them who uses nilotinib upfront for large number of patients. So I have a lot of patients who have achieved DMR very quickly and have remained in DMR. I have patients whom I have taken off the treatment exactly at 3 years, because that is what I promised them in the beginning, and their disease has behaved in that fashion, and they have understood that it's all 50-50 after stopping. So, and private practice is slightly different from a institute practice where the patient has a huge bond with you. You know that he's going to come to you. So more educated patient, little richer class of patient, understand what they're doing. A lot of young people, they've gone into the deep remission for good period because of second generation being used upfront. Early patients also, their so-called scores have been not so bad. So we stop at 2 years of DMR with a total of about 3 years with nilotinib as the first line. And we have exactly this figure of about 50% not going back to the treatment. So I think it needs to be individualized, especially in this country. When it comes to practice, research is different.
Thank you, sir. Thank you for your valuable.
Dr. Akanksha.
Yeah, good evening, sir. Thank you very much for the 2 wonderful talks. So my question is for Dr. Sanjeevan, sir. So I wanted to ask regarding the subset of patients where they tended to have an increase in the BCR-ABL transcripts after you had introduced the TKI discontinuation in those patients. So were there some patients who did not again achieve the sustained TFR after you reintroduced the imatinib?
So the answer is a big no. In fact, that is what most of the studies have also showed, that if we the very first thing is that we are taking, who are the patients we are taking up for TFR? It is those people who have achieved good early responses, who have achieved all their targets, they have been in deep molecular remission. So it means their disease is intrinsically sensitive to TKIs. So it's like a like what we see as steroid sensitive autoimmune disorders and all something. So it's something like a TKI sensitive disease. Now, once we take off their TKI, and for some still unknown biological reasons, why 50% of them will maintain their molecular response of imatinib, and why 50% or 40% of them will have a recurrence of their molecular relapse, as to say. We do not know the reason. But when we reintroduce TKI, probably the same TKI, it will again show a response. So in my small study of 37 patients, only 16 responded, required a reintroduction of TKI, and all 16, in fact, as I mentioned, between 2 months to 5 months. The earliest regaining of MMR was 2 months, and the latest was 5 months. So nobody has taken more than 5 months to regain a MMR.
Okay. And one question for MD, sir.
Before you ask that question, Sanjeevan, one thing I forgot to mention. I have patients who have taken imatinib for 10 to 15 years.
Sir.
Next foundation, of which almost 70 to 80% duration, they are in DMR.
Yes, sir.
When we have put them into TFR, there's a surprising figure. Almost 100% of them have not relapsed. It's a huge surprise to me. Of course, this kind of data is not published. 15 years of imatinib, of which 90% is in DMR, and now they go into TFR and they've not relapsed. One has to follow up and see what happens.
Yes, sir.
A standard 50% that we say is probably for those 3, 4, 5 years.
Exactly, sir. I think in the next 4 to 5 years, this thing will, when people will dissect out how these 50% are different from the others, probably this thing will come out. Duration may come out to be important. But the only thing is that, can we wait for 10 years in all the patients? Will it be justified? Yes.
Sir, can I make a comment with your permission?
Yeah, of course, Hemant. We are looking for that.
So, there was a publication from the results of the Euroski study by Suzanne, and she's shown very clearly that there is a linear relationship between the duration of TKI exposure and the degree of deep molecular response. And there is a 1 to 3% increment per year. So the longer the duration of the TKI, the more the chances of deep molecular response, maybe a negative ddPCR, and more the chances of a successful TFR. So that's and I have 4 patients who the GPAP people have permitted TFR. All the patients, all the 4 patients were 10 year plus. Some were 13, 14 years, and all the patients now are in deep molecular response. Not even one single patient has relapsed. I'm just kind of echoing your sentiments, sir. Thank you.
Hemant, what do you mean by they permitted you means what?
Sir?
They permitted you to put them into TFR means what?
Like they have a formal study, sir. They've selected 4 sites and they've given us each 4 patients, in which if the patient does have a molecular relapse, then they will permit that patient to restart Gleevec. And secondly, they are paying for the BCR-ABL also, sir. So that's what I want to say. There's a formal study in place. So I mean, you may want to know that. Thank you.
Yes, Akanksha, your second question.
Yes, sir. So I wanted to just know regarding the, is there any data on the potency of asciminib as compared to ponatinib?
So I have seen certain slides presented by guys in ASH meeting just now, the one which was just concluded in December. These are not head-to-head data, but they have pulled out data of asciminib and they pulled out data of ponatinib, put them side by side and showed you. And the outcome, which was very glaring, was the adverse effect profile of asciminib is far better than that of ponatinib. Efficacy wise, if you follow the formula of starting with 45, not less than that, then it matches. If the arms in which it was started with 30 or 15 all through, that was markedly inferior. So that was the sort of outcome of the whole thing, that if you want to go on ponatinib, be ready for the side effects, start with 45 and quickly get on to the 15 the moment you have achieved your goal. And asciminib, yes, of course, those kind of issues are not there. Safety profile is fantastic and it is on par with starting with 45 as far as the results are concerned. And
And I
then,
think there's another big plus with asciminib, sir. It can be, because the mechanism of action is different, it can be combined with the other
Yes, sir.
TKIs, and that
I would
work is
just-
also in progress.
no, that I was just going to quote that paper. So that paper was presented in ASH, where imatinib was combined with asciminib, and the data has been presented. In fact, probably tomorrow morning, I'm going to quote that paper. I prepared the slide for tomorrow morning. Yes. Okay.
Thank you.
Okay. Ashok.
Good evening to all. Thank you, MB sir, for a lucid presentation on unmet needs. And thank you, Sanjeevan sir, for excellent presentation on TFR, particularly the Indian studies you have shown. So as per ELN, the optimal TKI discontinuation criteria is the 5 years of TKI and more than 3 years of MR4 and more than or 2 years of MR 4.5. So in clinical trials, the success rate of TFR attempts is between 40 to 65. So my question is, if we, instead of stopping, after taking patient for TFR, instead of stopping suddenly, shall we decrease the dose gradually, like just like a studies in UK Destiny study? So I believe that will increase the TFR rates in CML. So what is the take on this, Sanjeevan Sharma sir?
No, the purpose of TFR is not to reduce the dose, because the off-target kinase effects, the TKI inhibition effects of a 200 mg nilotinib, and so that, say, why are we actually attempting a TFR is to save our patients from the adverse drug effects, say a cardiovascular event, a thrombotic event, or a renal failure. So it is not that, and nobody can study whether a 200 mg will damage the kidney less as compared to a 400 mg imatinib, or a 200 mg nilotinib will cause a lesser amount of cardiovascular adverse event. We do not know. So firstly, if we are unable to stop, just reducing the dose may not be the answer. The whole question is that we should not be bothered about recurrence, molecular recurrence. In fact, now that what I just heard from Dr. M.B. Agrawal sir, that he has gone ahead and actually done a person who was on upfront nilotinib at 3 years, and with the 2 years of DMR, he stopped. In fact, it could be a very good next study, that 3 years of upfront 2G TKI therapy with at least 2 years of DMR, you stop. Let us say 50, let us say 60% of them will relapse. Fine. These 60% we will restart on nilotinib. No problem. They will again regain their DMR. But at least these 40% people, we have saved them from their further TKI therapy in just 3 years' time. These other 60%, I'm giving you a very high figure. Let us say we failed in 60%. These 60% of the people in which we restarted TKI, now we will continue them for 5 years, because there is nobody to stop us from attempting a second TFR 5 years later. As Dr. Hemant sir also just mentioned, there is a linear relation. So, okay, this 60% did not go down to a level where their stem cells could be eliminated after 3 years of nilotinib. Maybe if we give them 6-7 years of nilotinib, that leukemic stem cell may get eliminated. And then when we attempt a second TFR after 7 years, we may be successful in another subset of patients. So out of this 60%, let us say another 30-40% we are able to eliminate then. So with every passing time, we can keep on reintroducing, get into a DMR again, 2-3 years of DMR, again try a second TFR, a third TFR, so because we should not be scared of getting a relapse. It is not like he'll go into a BC or an AP. But by reducing a dose to just 200 mg, we are neither this way nor that way.
So before and for 1 year we reduce the dose, we see how he behaves, and then we go for TF or something like that.
No, it has got because small amount of because we still have to realize that our molecular mechanisms which pick up a kind of BCR-ABL transcript. Now people are talking of a MR10 or MR7, but right now what is available is about MR4. What if a lower dose is maintaining the disease at, say, MR6? And the moment you take off, again, it will come back. So, but we have unnecessarily exposed this person to a lower dose of TKI, whereas if I would have stopped it upfront and the disease, the BCR-ABL transcript would have come back, I would know right in the beginning. And all these molecular recurrences take place in the first 6 months. So it's not that it's an endless process. 90% will take place in the first 6 months, 95% in the first 12 months, and 97% in the first 12 months, and only 3 to 4% will take place beyond 12 months. So in the first 6 months itself, I will be able to pick out those patients who are responding to TFR and who are not.
Thank you.
Thank you very much, sir.
Thank you, Ashok. Hemant? You are muted, Hemant.
I'm sorry. I'd like to congratulate Brigadier Sanjeevan for, doing this prospective study. Like I've been collecting retrospective patients for a long time. We have close to 40 patients now. But, doing a prospective study, putting it on the clinical trial registry. So salute to you, sir. Good job done. So my question to you, Brigadier Sanjeevan, is that if we were to plan a guidelines document for TFR in our country, would you suggest the same yardsticks as the NCCN or ESMO or ELN, or would you be a little more conservative? And my, one question was that how and why did you choose 7 years of exposure to TKI as your cutoff?
Sir, we went exactly by the first STEM study in which most of the patients who had taken TKI for about 7 years. So we had to give some kind of a number, and most of them are on imatinib. The NS10D, of course, took a 5-year cutoff, but the imatinib trial, because when this document was being prepared for ethical clearance, in fact, they wanted me to make it 10 years, which I said that, sir, if I make it 10 years, there will be a substantial number of patients who are right now eligible, they will suddenly become ineligible for this trial. People who had been maintaining a 0 BCR-ABL for 5 years or 5.5 years or 6 years continuously. If we make it 10 years, suddenly these people will go off. So let us stick to the 7 years, because in Mahon, FX Mahon in his initial study took a 7-year cutoff. So that figure of 7 was just taken from his study, not out of any great scientific work. And sir, I would agree. Your part one of the question.
If you were to make guidelines for Indian oncologists and hematologists, how much duration of TKI would you suggest for the
sir,
first
if it is
and for the second?
Because if it is for guidelines, sir, if the person is on a 2G TKI, I think 5 years will be, because when we say guidelines, mean it has to be based on some kind of a study. So we have got evidence to say that 5 years of 2G TKI with minimum 2 years of being in DMR is a good. And if the person is on imatinib, whether we keep 7 years or we give 5 years again is something which we all can sit and discuss, that ultimately how is going to make a difference.
So
all
one
that
one question to Dr. Agarwal, sir. When you have used, when 3 TKIs have failed, the first, second generation, and you're using a 3rd generation TKI or a 4th generation TKI, meaning ponatinib or asciminib, then do you think it is a bridge to transplant? All these patients should be evaluated for transplant, or can you keep the patient who's doing well on these agents indefinitely, like you do for in the first line setting and in the second line setting?
Absolutely. I'm not thinking of this as a bridge to transplant at all. As these drugs fail or become patient is intolerant to these drugs. So if those who have tolerated, those who are doing fine, they have achieved their goals. I would rather, try, as you just said, Sanjeevan said, 3rd time TFR or 3rd line TFR. No, not at all. This is not a concept that I'm using them as a bridge to transplant. If they cannot have an access to these 2 drugs, they could not tolerate, or these drugs fail, they will be state candidate for stem cell transplant if they are eligible. Large number of patients are still for stem cell transplant rather than these drugs.
So just for your information, Brigadier Saab and others, I'm on the ELN panel this year for guidelines for 22-23 for CMLs, and all your inputs and suggestions are welcome. And please publish your study quickly so that, I can use that and, have our level 1 evidence and talk to them that way. Thank you very much.
Sure, sir.
Thanks, Hemant, and congratulations. Bharat?
We had a wonderful academic quiz, sir, today. And Dr. Sanjeevan has already answered my query that will you safely go for second TFR in this subset of 16 patients, and at what period? After which period? Because you have already mentioned that it was easy to again achieve remission in this group. So this time, how much deep molecular response you want to achieve? And
Sir,
when you will plan second TFR?
Sir, ultimately, TFR can be started only if we go down to undetectable MRD level. So that the only thing, the question will be duration. So now out of the 16 patients in which I had to restart, some of them in which we were a bit early, or one of the lady, she wanted to conceive, and that is why she wanted to go into. So there, of course, that's a different story. We will give them at least 5 years, 6 years of imatinib therapy. But there have been some patients who took 10 years of therapy. And again, one little thing, although it's such a small study of 37 patients, I have found that pediatric patients don't do well at all in surprising. That was a surprising part. So there was this child who got diagnosed at CML at 2 years of age. And she came to me, initially she was on interferons and all that, so pediatric CML. And when she was 18, because the trial mandated that minimum age would be 18 years so that they are able to sign on the consent form, we gave her TFR trial at 18 years of age, so that she had already taken 16 years of imatinib. And she was on deep molecular response. And unfortunately, she, within 3 months, her disease, BCR-ABL transcripts came back. Same thing happened to another boy who got CML at 12 or 13 years of age. And after this thing, some of the pediatric patients I have seen did not do well, pediatric CML, that is to say. But yes, achieving a second DMR will be an absolute mandatory. And maybe I will just increase the amount of time at which the first TFR was taken. So if it was done at 3 years, maybe this time I'll say 4 years or 5 years, and so on and so forth.
Thank you. We will eagerly wait for the sub-analysis or data for those 16 patients. One small question for Dr. Agarwal, sir. You have wonderfully mentioned about the SCMID studies, and you have mentioned 2 dosage, 40 milligram BID and 200 milligram BID. Why is the difference? And is there any relation with mutational status in failure with the second generation TKI?
Absolutely. It's clear cut now. That's only for the 315 that you are going for 200B. Rest all, you are going to go for the 40B. So that's the standard. That's the approval. So you do not use the higher dose for the routine cases.
Thank you, sir.
Okay, Aishwarya.
Thank you, sir, for the wonderful talk. Sir, basically most of the aspects have been covered. So I just wanted to discuss a case. We have a young 28-year-old chap who got diagnosed 2 years back, CML CP, and has been on imatinib since then, 400 mg tolerating quite well. And for the past 1 year, he has been in deep response. So the question now is he wants to get married, and the apprehensions from the girl side is what about the if they want to plan a child early. So he needs to address these questions, and he's asking us for the same guidance regarding the same. So in this scenario, how should we plan his therapy? Going for trying to risk a TFR, or switching to something interferon or something, how should we go about in this case?
Aishwarya, this is what you are saying is only for the girls. As far as the boys are concerned, there is no issue at all. They can, their wives can become pregnant even when they are taking any one of the TKI. So there's no issue at all. So they don't have to rush to the TFR just because they want to father a child. Are you there, Aishwarya?
Hello?
Yeah, are you there?
Yes, sir. Yes, sir. Sorry. The males can continue the TKI even like when they are
Yes. They want to
trying.
plan the family. They can father a child even when they are on any one of the TKI.
Okay.
Absolutely no issue of any problem of fetal losses or malformations.
In fact, sir, I'll just put why this question has come again, because in army we face this problem day in and day out, because most of our soldiers are young, and when they come, because in the environment there is, because probably people have extrapolated the data of teratogenicity in the female patients to the male. Plus, there was some reports earlier of tyrosine kinase inhibitors causing defective, because if you go into any study, so in animal models, they had a defective sperm functioning. So that led to a kind of a fear in these, that, but none of these patients have ever been known to have any teratogenicity. So people who were on TKIs and they have fathered a child, not a single case of teratogenicity has been documented of fetal malformation. So as far as your patient, Dr. Aishwarya, he's concerned, you can absolutely tell if the person is on DMR, he continues his TKI, and they don't have to bother about teratogenicity aspect at all.
Okay, sure, sir. And sir, another question, like patients who have this T315 mutation initially start somehow they manage. Hello.
We lost your voice.
Yeah, just got muted in between.
Another young guy with T315 mutation somehow managed to get procured ponatinib for some time, but ultimately had to go for a stem cell transplant due to monetary issues. Now, post-transplant maintenance, like what options do we have for this chap? Again, because money is a concern, he cannot go for long-term ponatinib or something. Like, what options do we have for a post-transplant TKI maintenance, and how long?
So recommendation is 2 years, but if there is a financial issue,
Okay.
ponatinib is not cheap and not officially marketed. So you have discussion on a non-scientific front.
Okay, sir. Sure.
I hopefully he is negative.
Yes, sir. He's negative, but
Yeah,
like
I understand. So officially, yes, 2 years one would like to give, but then practical issues are there for you.
yes, sir. So, like, if he cannot afford, we'll like, should we continue without any and just keep monitoring his, or
You have no other, because other TKIs are not going to work.
Yeah.
Data on interferon in this situation. So you have absolutely no way to go beyond this. Just one piece of information, Hetero can provide you with the ponatinib at a reasonable cost, not very cheap, but reasonable cost.
Okay, sir. Sure, sir. Thank you, sir. Thank you for the talk.
Thank you. Dr. Krishna Ratnam?
No, it's just a extension of the previous question or the comment. I think the TFR is very extreme, will also be useful in women of reproductive age who wish to become pregnant, and we had webinars on that. So the ideal scenario for a woman to get pregnant would be when she is TFR eligible. So any extra comments on that, sir?
Sanjeevan?
Sir, it depends on the age of the lady and the wishes of the family, because if the, like, this is a real-time case, which lady who just walked into my clinic with a newly diagnosed CML, and she was 24, 25 years of age, and she's got a long period ahead of it. So then in that case, we go for just a MMR and then switch over to interferon, what has been the standard of care for these people. Switch over to interferon, go through the 9 months or 1 year of gestation, and then restart TKI after the delivery of the baby.
Yeah, fine. As you said, depending on the age.
Exactly,
But
sir.
if they are TFR eligible, that will be the ideal scenario.
Yeah, ideal, sir. Yeah, but many times, sir, you may not find young 22, 23 years old. The more practical thing is, a 27 or a 30-year-old lady coming to you where the minimum period, and that too, she should be able to afford nilotinib or a dasatinib upfront for a minimum of 3 years period. So that may be a challenge. But yes, ideal would be TFR eligible, 2G TKI, minimum 3 years, try for a TFR, and during TFR, go ahead and plan the family.
Dr. Krishnaratnam, there is data from Italy that if you are pressed, you can use TKIs during the second and third trimester.
Second and third, yes, sir.
Without any mishaps. And a data of 200 plus pregnancies. So that is also very reassuring that if someone relapses, you have drugs which you can use reasonably safely. And there are some social issues again over here. We've had families where the maternal side, the girl side, have come and said that the girl will be divorced if she will not have a child in this year. You have to take that into consideration in Indian circumstances. So that is going to ruin the life of that girl much more than all this scientific discussion that we are doing here. So sometimes you have to be liberal with things. 50% of women can have normal child on TKIs, who have taken through and through TKIs, who have become pregnant on TKI, come to you directly in the 6th month of pregnancy. And the data is that 50% of the fetuses are normal. So these are some social issues. Any more questions from anybody?
So can I ask Roshni?
Yeah, Roshni, go ahead.
Yeah, good evening. For Dr. Sanjeevan, does the type of transcript matter, E13A2 versus E14A2?
Ma'am, I have not come across any data as to the type of transcript and the success of TFR. Ultimately, it is the molecular response alone which determines. But if somebody has done this dissection of people who have relapsed and people who have continued based on the type of transcripts, then that is something I need to look up. But I have not come across any such data.
The issue there is that you should have quantitative monitoring.
Exactly. So it has to be a transcript which can be monitored on an international scale.
Yeah. Second is, what about ddPCR versus RQ-PCR? What is the difference and does it matter, or should we use the same kit each time?
The RQ-PCR is the standard as of now.
Yeah.
And of course, the DG-PCR is coming up, but it is not yet widely available. And most of us don't have an experience with that. Of course, it is going to give us much deeper responses, maybe up to MR7, some people are saying. But right now, for all practical purposes, MR 4.5 to MR 5, which is available on standard RQ-PCR, is good enough. Because if our ABL copies are more than 1 lakh, which is very usual in most of the labs, if you see 1 lakh ABL copies, they are able to generate. So that is good enough.
And the third question
versus NGS. You want to do NGS, but all the issues are there.
Yeah. The third question is, many patients who can't afford, we just do the RQ-PCR and then start the imatinib. Now that Hammersmith score does mention the baseline cytogenetics. So does it matter when we have patients now who are 10 years into therapy? Does that criteria matter to us at all? I mean, do we need to do bone marrow cytogenetics upfront for all, which practically we are not able to do?
Ideal recommendation is yes, because only if you want to pick up additional cytogenetic abnormality. So there are, of course, that's an entire issue in itself. Upfront at diagnosis, the advantages of doing a bone marrow biopsy, although that percentage may be small. So we'll not be able to pick up a fibrosis if we don't do a upfront biopsy. If we have an upfront additional cytogenetic abnormality and if we have not done a karyotyping, we'll not be able to pick that up. So those little issues are there, but then their entire thing falls into less than 5% category. So 95% of our patients just with a peripheral blood RQ-PCR will be able to manage them as well as we are doing.
The next question is for Dr. Agarwal. This is a patient I have shown you earlier. She was on imatinib for about 4 or 5 years. After that, due to rising BCR-able transcript, I had increased the dose of imatinib to 600 in those days. This was around 10 years back, probably. Then she developed G250E mutation. So at that time, we discussed and we put her on nilotinib. She's diabetic. She developed myocardial infarction and a stroke. So then we shifted her to dasatinib 100. Now she developed pleural effusion after a year. So we stopped for some time and then I re-challenged with dasatinib 50 because there was no other option. I went through all the data, etc. Now she was okay for several months on dasatinib 50, again developed pleural effusion, and that kind of pleural effusion required ICD on both sides. And she also required steroids. After the steroids, she stopped pouring out so much of effusion. Otherwise, it was 5 to 6 liters per day. So after that, that story of further re-challenge was over. Now the thing is, she's transplant ineligible, and because of the stroke, she has to be assisted in activities of daily living. So in that kind of scenario, though she is MR 4.5 still after 5-6 months of stopping dasatinib, should we look for asciminib on compassionate ground? Is it available, or should we just continue to monitor her?
So you are saying TFR versus starting another line of treatment.
I mean, what is the option for her?
That is your question, right? TFR versus starting asciminib.
Yeah, so far we have continued on TFR, but one is always afraid that she will relapse, and then we'll start looking for a drug which we won't be able to access at that point in time.
So how long was she in DMR before you have stopped her treatment?
We stopped treatment because of pleural effusion, and prior to that because of nilotinib-induced stroke.
My question is very different. What was the duration in which she was?
So to first line?
Due to pleural effusion, but no. Just now, when you stopped the treatment few months ago.
6 months.
Only 6 months she was in DMR.
But she's continued to remain in DMR, whatever we have done, whether she has been off.
So it's very clear, if she has remained in DMR, irrespective of what you do, she should be in TFR. Why should she go to asciminib?
Exactly.
There's a 50% chance that she may never relapse. She has had enough and enough of TKI with all their toxicities. She's remained in DMR for years. She's a perfect case for TFR and not for asciminib.
And supposing the BCR-able transcripts start rising, do we need to, start worrying because she has had so much intolerance to different therapies, or should we, just keep on observing and be happy with what we have got?
No. How can you be happy if the MMR is crossing the dividing line of 0.1, then she needs treatment?
No, if she's in MMR, if she continues to be in MMR but not in DMR.
So that's good enough, because
that's good enough.
Yeah, that's good enough.
That should be good enough. Thank you, sir.
And never forget interferon. So patients who cannot go for anything and they are on interferon and doing pretty well, tolerating also and doing pretty well.
And is asciminib available in India, or can it be accessed?
Compassionate basis from Novartis. We have got patients through them at the moment free of cost.
Thank you so much.
You need to spend a little time to do the paperwork. Your patient has to be intelligent enough to do some paperwork.
Yeah.
You have to have patience for about a month or two by the time you can get the drug. So we have had patients who have taken ponatinib for 2 months and they know that they cannot go on and on with ponatinib. So simultaneously they have started working with Novartis, got the drug and switched over from ponatinib to asciminib. So
thank you, sir. And thank you, Dr. Sanjeevan.
Right.
So I suppose there are no more questions, and this is beyond 9 o'clock. So Sanjeevan, you are missing your party. So thank you so much for being with us. Thanks to all the discussants. Thanks to Novartis for supporting this. Thanks to Nirvin, and thanks to Kalpesh and his team for managing the show. And those of you who are interested, come over tomorrow morning, 11:30. We have the next webinar. Bye-bye then. And bye.
Thank you. Thank you so much for the kind opportunity, sir.
Bye-bye. Bye.
Bye, sir.